a great pleasure to welcome Professor Thomas Keynes. He probably doesn't need much of an introduction to most of you, but I will just briefly say that he is Professor Emeritus of Pediatrics, Physiology, and Neuroscience at the Keck School of Medicine and Children's Hospital, Los Angeles. He earned his BA in Liberal Arts at St. John's College in Santa Fe, New Mexico, and an MD at UC San Diego School of Medicine. He's been at USC since 1977 with several adjunct and visiting appointments at UCLA. He's distinguished for his research and clinical practice in a variety of fields: cystic fibrosis, sudden infant death syndrome, congenital central hypoventilation syndrome, and home mechanical ventilation. And he has about 200 peer-reviewed publications to his credit. He's won many awards and honors for his contributions in all these fields. Tom will speak to us about his career for a while, and then we'll throw it open to questions and discussion. So, Tom, please take it away.
Okay, thank you very much for inviting me to present my intellectual journey today. I have to say that I may not be worthy of trying to offer wisdom to this illustrious audience. And as the ancient Greek philosopher Anonymous once said, old age is obligatory, but wisdom is optional. So as mentioned, I'm a Professor Emeritus of Pediatrics, Physiology, and Neuroscience at the Keck School of Medicine, and was a pediatric pulmonologist, and actually for a brief period of time, about half my career, a neonatologist at Children's Hospital Los Angeles. I started on the USC faculty in August of 1977, and I just retired in June 30th, 2023, after 46 years. So two themes have influenced my career. One is fate or luck. A giant in our field of pediatric pulmonology, Julius Comro, defined serendipity as looking in a haystack for a needle and discovering the farmer's daughter. I spent my undergraduate education at St. John's College, which has a program where the great books of Western thought define the curriculum. For me, this was a wonderful experience, and my freshman year was spent immersed in the study of the ancient Greeks: Plato, Aristotle, Homer, Euclid, Ptolemy, Euripides, to name a few. I have to say that I was puzzled by the emphasis many Greek philosophers and poets placed on fate. But I've come to understand over the years that many things in my career happen because of fate and not necessarily because of intention. The other theme is that I've achieved very little, if anything, alone. Virtually everything I have achieved has been due to collaboration with my mentors, my peers, and my trainees. USC football illustrates the importance of teamwork. The USC football team is, to my knowledge, the only college team, or maybe one of the few college teams, which does not put the names of individual players on their jerseys. There's no I in team, and so it is with science and medicine. And as Sir Isaac Newton once said, if I seem to see further than others, it is because I stand on the shoulders of giants. I have at least 4 giants who I consider my mentors, who shaped my career and changed my life, one of whom is in the audience today. So when I started as a medical student at UC San Diego in 1968, we were all assigned faculty advisors. Of course, this was somewhat at random, as the faculty had no way of knowing what each student ultimately wanted to do. And my faculty advisor was Gennaro M. Tisi, who had just completed his fellowship in pulmonary physiology at the prestigious Cardiovascular Research Institute, or CVRI, at the University of California, San Francisco. If you've ever taken a basic human physiology course, you probably remember that the lungs are not taught in a very interesting way. Therefore, I was not particularly excited about having a pulmonologist as my advisor. But I wasn't sure why we needed an advisor anyway, so I didn't worry about it. About halfway through my first year, I went to Dr. Teese to ask about any possibilities of summer jobs in the medical school. I've never seen anyone do this, but he jumped out of his chair, literally leapt straight out of his chair. He said, "You can work for me." And he ran me from the basement to the 11th floor of the hospital to show me his pulmonary labs. Still not too excited, but having no better offer, I took it. So fate dealt a hand. Because the pulmonary system came later that spring in our first year physiology course as medical students, and knowing that I would be doing that for the summer, I paid a bit more attention to it than I might have otherwise. When I arrived in the pulmonary division that summer, they said, "Tom, you did really well in pulmonary physiology. You can help teach the fellows." Well, no, I could not teach the fellows, but I learned with them. Jerry Teasy held a daily pulmonary physiology session where we could ask him anything. Even describing a patient would end up with an hour-long physiology discussion prompted by the case. He was a charismatic and enthusiastic lover of physiology, and his teaching of the subject was infectious. By the end of the summer, I was hooked. Respiratory physiology was the coolest thing, and I knew I wanted to do that for the rest of my life. So Jerry Teasy was my first important mentor. That summer, he initially threw me to the pulmonary function technicians to learn how to do pulmonary function tests. This was invaluable for my subsequent career running a pulmonary function laboratory. I knew firsthand what PF techs could and could not do, and I could advise them from experience, not just from textbooks. UCSD Medical School required a thesis for medical students to graduate. So I worked on research for my thesis under Jerry Teasy's direction. On completion, it was titled "The Regional Ventilation Perfusion Profiles of the Pink Puffer and Blue Bloater, a Pathophysiologic Basis for the Divergent Pattern of Breathing." Sounds pretty impressive, doesn't it? I presented this at the American Federation of Clinical Research annual meeting as a senior medical student. I was intimidated at the time, but I survived. As a mentor, I have to say Jerry Teasy taught me to love pulmonary physiology. He was so enthusiastic about it that you wanted to learn it. I hope to model my own physiology teaching after that. As I neared the end of medical school, I knew that I wanted to be a pulmonologist, although that term was not then in common usage. The only question was internal medicine, where all exciting pulmonology seemed to be happening, or pediatrics, which was a relatively uncharted territory. I just had more fun taking care of children than I did adults, so I took a chance on pediatrics and ultimately the uncharted territory of pediatric pulmonology, a decision I have never regretted. Again, fate dealt a hand. In 1972, I matched to for my pediatric internship and residency at Children's Hospital Los Angeles, which was my first choice. CHLA did not have a pediatric pulmonologist during my intern year, which was not unusual for major academic centers because there were so few of them. Some rheumatologists had pulmonary function tests performed on their patients outside Children's, as there was no pulmonary function laboratory. Because of my experience as a medical student, they would bring the PFTs to me to interpret. I was just an intern, but there was no one else at the time. Into my second year of residency, my second great mentor, Arnold Platzker, who's on the audience today, arrived at Children's Hospital to begin a neonatal and pulmonary program. He had also trained at the prestigious CVRI at UCSF, and he was an expert in both neonatal perinatal medicine and pediatric pulmonology. After his arrival, he heard by rumor that there was a resident interested in pulmonary. Happened to be me. He tracked me down, and he met with me several times to plan my future. He was aware of the best respiratory physiologists in North America, and he recommended that I look into these fellowships. Remember, this was before the internet, so it was not easy to find out about fellowships at that time. Again, fate dealt a hand. How many faculty members would take the trouble to seek out someone he did not know on a hunch that he might make a difference in his life? That advice changed my life and set my career in motion. Although I did not really want to be a neonatologist, I enjoyed neonatology because there was so much fascinating pulmonary physiology involved. In that era, as a pediatric resident, I would volunteer to go on transports to pick up sick newborn infants and bring them back to our neonatal intensive care unit, or NICU, now a state-of-the-art facility, thanks to Dr. Platzker. In those days, you applied to fellowship training about a year and a half before actually starting. So I went to visit the fellowship at the Hospital for Sick Children in Toronto, Ontario, Canada, also known as Sick Kids. As a resident, not making much money, I asked if there was an on-call room or someplace I could stay overnight so I would not have to pay for a hotel. Henry Levison, ultimately one of my two mentors at Sick Kids, said I could come stay with him. This was a little bit closer than I had hoped for, but he insisted. Henry did not drive, so he gave me instructions how to get from the Toronto airport to his apartment by bus and subway. I showed up at around 8:30 p.m. He opened the door and immediately said, "Don't step on the art." Now, Henry was a art collector, but the art I could not step on was a large oval piece of iron about 6 inches thick with 2 diagonal lines cut through it. I could have jumped up and down on it, never made it down. Nevertheless, I did not step on it. So the next day, we went to Sick Kids, where I was very much impressed by the program and decided that that would be my first choice. A few weeks later, I received a telephone call from Henry offering me the fellowship. Among other things, he said I would have to find my own funding, to which I asked, what if I couldn't find any? He said he would accept me anyway, but I should try to get a grant. I immediately accepted his offer. We then had a little chit-chat, and he asked about the weather. Now, I now know what the weather was like in Toronto in February before global warming. But we were having one of those February heat waves, and I told Henry it was about 85 degrees Fahrenheit. There was silence on the phone for what seemed like minutes, when Henry finally said, "You bastard." To which I still remember saying, wait, I still have a job, don't I? The weather's not my fault. Well, I did get the job. It turned out I also did get 2 fellowship grants. One from the American Lung Association, which at the time was the more prestigious, and one from the Cystic Fibrosis Foundation. However, the Cystic Fibrosis Foundation paid $500 a year more, so I took that one for a grand total salary of $11,500 a year. This was in 1975. So, back to residency, Arnold Platzker brought a whole new understanding of pulmonary physiology and clinical medicine to Children's Hospital. As a pediatric resident, I tried to follow him as much as I could, and I learned the basics of clinical pulmonary medicine from him. He made the little-known field of pediatric pulmonology exciting, and I was looking forward to my upcoming pediatric pulmonary fellowship in Toronto. In those days, pediatric fellowships were 2 years. The first year was generally a clinical year, and the second year was a research year. So I arrived in Toronto in July of 1975, which happened to be the 100th anniversary of Sick Kids Hospital. When I arrived, I was met by Henry Levison, who informed me that I was a research fellow for 2 years, no clinical training. I actually wasn't quite sure what a research fellow was supposed to do. My experience in residency training was just patient care. Charlie Bryan was out of town, and I would meet with him the next day. Henry warned me, Dr. Bryan does not suffer a fool. So the next day I met with Charlie. It was a brief meeting. He handed me a preprint of a paper from Harvard on ventilatory muscle training and suggested I do my research project on ventilatory muscle function in CF, or cystic fibrosis. Then he turned around and returned to his work. Muscles? I came to Toronto to learn about the lungs, but I kind of got the idea from our meeting that Charlie did not really want to talk to me again until I had something to show him, that is, research results. In retrospect, this was great training. I had to work out my own research project largely on my own, of course, with advice from faculty and others. And this was ultimately training which would benefit me when I later came back as faculty to Children's Hospital Los Angeles and USC, which did not have the research infrastructure, at least in pulmonary, that Toronto, which was really a research mill, did. I have to say I was distracted in Toronto at first. There were so many exciting research ideas that different faculty offered me that, oops, sorry, that I committed to about 10 of them by the first month that I was there. I was like a kid in a candy shop, but obviously I could not do them all. It probably took me close to 6 months to realize that I could not do all of those projects, and I had to let some go by and only work on the ones I felt I could actually do or that interested me. In fact, Charlie Bryan later told me that he had given up on me for the first 6 months. I did settle down, however, and earned his respect back. To make a long story short, I did complete a fairly comprehensive clinical study of ventilatory muscle endurance and training in cystic fibrosis. But I was concerned that the techniques were so effort dependent in patients. They really had to do a fairly tedious sort of technique of rapid breathing at high levels for up to 20 minutes. Among other things, it was quite boring. But because this was so effort dependent, I just wasn't quite sure these results were true. So I happened to meet a basic muscle physiology at a neighboring university. This is sort of like doing my fellowship at USC and then working on a project at UCLA. We essentially validated my clinical results in a rat model. This was a great experience, but I'm primarily a human physiologist, and I couldn't really duplicate this kind of basic science laboratory when I came back to the faculty at Children's Hospital. So Henry Levison and Charlie Bryan were my third and fourth most important mentors. They really taught me physiology and how to do research. They were very different researchers. Charlie had brilliant ideas, which he tested on one or two subjects. Thus, a Bryan unit was one research subject. Henry made observations on large groups, usually had 100 subjects or more. Thus, a Levison unit was 100 research subjects. I actually dubbed these titles. I decided to take the geometric mean, and I called a Keynes unit 10 research subjects. In fact, much of my research has consisted of one or two Keynes units in terms of numbers of patients. I loved my fellowship, and I was very successful. Now, Arnold Platzker back at Children's Hospital Los Angeles started to write me in my first year of fellowship. Remember, no email in these days. Asking what I was doing, how I was doing, etc. We wrote back and forth a few times, and they finally wrote that he was planning the budget for the 1977-1978 academic year, and would I be interested in coming back on the faculty. I knew the potential CHLA had for a great pulmonary program, and my wife's and my families were in Southern California, so I accepted his offer. I was going to do pulmonary, but his division was combined with neonatal perinatal medicine, so it would also be an attending physician in the neonatal intensive care unit. I don't know if Arnold ever realized that I never really had a clinical fellowship in pulmonary, much less one in neonatology, but he hired me anyway. So I arrived at Children's Hospital as a USC assistant professor in August of 1977. I was excited and ready to take on the world. Arnold offered me the pulmonary function lab to run, which I loved. I've always considered myself a physiologist. Since I never had a clinical fellowship, I leaned on Arnold and continued to learn my clinical pulmonology from him. He was a great boss and a great mentor. He gave me freedom to explore areas and ideas, and he always supported me. My career would not have been the same without the freedom and support he gave me. Hopefully, I repaid him. He's looking fairly somber there at the moment. Let me review a few highlights. So I've been a Cystic Fibrosis Foundation funded fellow, and my research in Toronto was largely cystic fibrosis oriented. However, at the time at Children's Hospital, the cystic fibrosis program was separate from pulmonary. Though I had proposed some interesting research ideas to the CF program chief, she ultimately said, "No, you're not in my division. You're not helping me by seeing patients. You can't do research on them." Ouch. Fate struck a hand. I did not know what to do. So I went to Arnold and asked, what should I do? Apparently unperturbed by my situation, he said, why don't you work on sudden infant death syndrome, or SIDS? Nobody's doing that. So in Toronto, I was doing research on ventilatory muscles, And Charlie Bryan had other fellows working on respiratory control. He developed the idea of the respiratory balance. That is, the respiratory system is not just the lungs, but ventilatory muscle power, the diaphragm, for example, and central respiratory drive, the brain telling you how deeply and frequently to breathe, need to be adequate to overcome the respiratory load. If they were not, you had inadequate ventilation or respiratory failure. So I was used to thinking about not just the lungs, but also the muscles and the brain in terms of breathing. So I took Arnold Plasker's advice and began to think about SIDS. In the late 1970s, most people thought that SIDS was due to an infant stopping breathing, the so-called apnea hypothesis. Apnea means not breathing. But have you ever watched a baby breathe while asleep? It can scare you to death, especially if it's your own baby. They do not breathe regularly. They have pauses, they sputter, etc. Their breathing is not regular, and they all have pauses or apneas. We reasoned, since all babies have these pauses, maybe it's not so important to understand why they have pauses. Maybe it's more important to understand how they rescue themselves from an apnea than why they have the pauses in the first place. The best thing you can do if you're in a potentially dangerous situation during sleep is to wake up and deal with the problem. With my first research fellow, Sally Ward, and subsequent fellow, Rafika Ursu, we studied arousal or waking up from sleep induced by hypoxia or low oxygen. We exposed infants to the oxygen equivalent of being at about 10,000 feet elevation for up to 3 minutes to see if they would wake up. It turned out that about 50% of normal infants aroused at 1 month of age, which was younger than the peak incidence of SIDS. But almost none aroused at 3 months or 6 months. 3 months is the peak incidence of SIDS. Thus, we believe that although the lack of arousal may not cause SIDS by itself, perhaps combined with other factors, it may make infants more vulnerable at this age. Arousal has continued to be an important line of SIDS research. Dr. Ward later became my division head. When Arnold Plasker retired, I never wanted an administrative job, and I succeeded in avoiding this my entire career. In the 1990s, we also were part of the CHIME study, Collaborative Home Infant Monitoring Evaluation, a NIH multi-center trial to look at apnea pauses that babies had during sleep. We designed a monitor which would measure both central and obstructive apneas, heart rate, oxygenation, etc. And at that time, using home monitors was a popular thing for babies thought to be at increased risk for SIDS. With the CHIME study, among other things, we showed that the types of apneas that babies were having or were being detected on monitors were in fact found commonly in normal infants. And it kind of put the nails on the coffin, if you will, of the apnea hypothesis for SIDS. We also showed that apneas occur much earlier in life than SIDS occurs, so they don't really correspond. I do remain active in my retirement as chair of the California SIDS Advisory Council, which is legislatively mandated to advise the California Department of Public Health on SIDS issues. This is not so much research as it is advocacy and education. Now, when I first arrived at Children's Hospital on faculty, there was an infant who Arnold Plasker diagnosed with a very rare condition, at the time called Ondine's curse. Since families do not like their child having a disease which is called a curse, we now call them congenital central hypoventilation syndrome, or CCHS. This is a rare, we now know, genetic condition where babies don't breathe when they fall asleep. There is no cure. Therefore, this infant would have to use a ventilator every time he went to sleep for the rest of his life. However, if we did our job right, that is, provide him with sufficient oxygen and ventilation when he slept, he could turn out well. Arnold said to me, "You train with Charlie Bryan, you know about respiratory control, you can take care of him." Thanks, Arnold. Because this child could otherwise do normal things, we did not think he should grow up in a hospital. So he was the first child we sent home on a ventilator in November of 1977. This was a scary proposition, as in those days, the only people on ventilators were in ICUs, definitely not at home. Again, Arnold Plasker held my hand and supported me during this very nervous adventure. I did not know if we could keep him alive on a ventilator at home, but we did send him home, and he's still alive and doing well at age 47 years. The word got out, so we started being referred CCHS patients from around California and ultimately from across the country and even some foreign countries. Now, with a relatively large number of CCHS patients, this rare disorder, we started to study their physiology. We all knew they did not breathe well asleep. How about when they're awake? The major thing keeping you breathing is central chemoreceptors in your brain. It senses CO2 and works like a thermostat. If CO2 gets too high, the brain stimulates breathing to turn it down. If CO2 gets low, the brain inhibits breathing to bring it back up. There's a similar control for low oxygen. We performed these ventilatory response studies to CO2 and hypoxia in CCHS children while they were awake. They did not respond. Ultimately, this led us to understand the most important clinical problem dealing with these patients. If any of you in the audience have a pneumonia, severe pneumonia, or low oxygen, you will become agitated, breathe rapidly, have nasal flaring, indrawing of your ribs, etc. However, all of these signs, which every medical student learns, depends on intact ventilatory control, which is absent in these children. Therefore, they can be seriously ill with low oxygen, but they don't give you any clues that this is happening. We went on to show that body movement can stimulate breathing in both CCHS and in normal individuals. As an example of the importance of this, one of my CCHS patients was in the 2nd grade. Her mother did not tell her teachers that she had CCHS. She just told them that her daughter should not be allowed to take a nap at school. Remember, they don't breathe when they fall asleep. Her very astute 2nd grade teacher noticed when the class was sitting quietly doing schoolwork after about 20 or 30 minutes, my patient looked pale. So she decided my patient should stand up, take a few breaths, and move around every 10 minutes or so. But she didn't want to single out my patient alone, so she had the whole class stand up every 10 minutes. And she noted later that the whole class did much better on their work. So the importance of showing that body movement stimulates breathing in CCHS was that although they have absent responses to low oxygen and CO2, they have other mechanisms that stimulate breathing. One must have redundancy of crucially important physiologic functions. Breathing is too important to have only one mechanism to control it. Now, as I mentioned before, we discharged our first child from the hospital on home mechanical ventilation in November of 1977. I don't know if we were the first group to ever do this. Some have suggested that we were, but we were one of the first groups. And we were successful. We could keep children alive. Therefore, centers from around California sent us infants and children who required chronic ventilatory support. It was not long before we had a very large service. I never thought of this really as an academic career direction. It was just something we did because the children needed it. However, in around 1990, somebody noticed that we had a few hundred children on home mechanical ventilation, and I started being asked to speak about this at national and international meetings. We were the experts. We then started to publish a number of papers on how to do this. And with our nurse care managers who developed an interest and expertise in this area, we looked at what parents and nurses who care for these children at home actually know. They're the ones who have to respond in the event of an emergency at home. We're not there. We discovered that an area where their knowledge lacked was response to emergencies in the home. In fact, about 10% to 20% of deaths in these children were possibly due to an inadequate response to an emergency in the home. We reasoned that with better training for parents and in-home nurses, we might prevent some of these deaths. Our nurse care manager, Sheila Kuhn, convened a group of home mechanical ventilation experts to determine what types of emergencies occurred at home and what you should do about them. One thing that we found was the first thing you should not do is call 911. The paramedics would likely get there too late, and they probably would not know as much about children on home ventilators as the parents did. Using this knowledge, we developed and published a unique educational program for parents and in-home nurses on how to recognize and respond to emergencies in the home. We remain a resource on home mechanical ventilation in children. What I ultimately enjoyed most in my career was working with fellows, not only teaching them clinical medicine on the wards, but also teaching them research. I was director of our Pediatric Pulmonary Fellowship for about 30 years. Much of the research I did was because I convinced fellows to work with me. I gave them projects, and they were rightly first authors on presentations and papers, but we got a lot of things done by motivating fellows to work with me. In 1999, I was a visiting professor at Hershey Medical Center in Pennsylvania for about a week. My former co-resident, Steve Wasner, who was a resident with me at Children's Hospital Los Angeles in the early 1970s, was the vice chair of pediatrics at Hershey, and he invited me out. I remember as he introduced me for a conference, primarily for residents, he made an observation I had never thought about. I had about 100 peer-reviewed publications at that time, and he noted that I was first author on only about 5 of them. My fellows were first author on the rest. So not only did I do research, but I taught it, and I hope shared in my enthusiasm for it. This really is one of the most satisfying parts of my career. As an aside, I should mention that I was the chair of the Children's Hospital Los Angeles Institutional Review Board for about 25 years. This is an interdisciplinary committee that reviews all human research to assure that the rights and welfare of human research subjects are protected. Well, I was certainly confronted by many faculty who felt that IRBs are an unnecessary obstacle to research. I would like to think or hope that I did the job with a common sense approach. I tried to improve human research ethics through education, and in many ways, I was the resource for ethical conduct of human research at Children's Hospital. I actually achieved a measure of respect from most faculty for this role. Finally, about 12 years before my retirement, my career came full circle and returned to cystic fibrosis. When Arnold Platzker retired, he was director of the Children's Hospital Cystic Fibrosis Care Center, and so a national search was held to find his retirement. No one seemed interested, and so I was chosen. I used to tell people that I was the last choice for the job, but actually I loved it. I had a wonderful, talented, and dedicated group of many healthcare professionals who were required to care for the children with this very complex disease. I viewed my job actually as just staying out of their way so they could achieve great things. I adopted Arnold Platzker's leadership style, give them the freedom to innovate and create while supporting and encourage them to succeed. As we were one of the elite CF care centers in the Therapeutics Development Network, I got involved in clinical trials to enhance and extend the lives of people with CF. By this time, I was a tenured professor, so I could afford to be involved in this critically important type of work for which I would likely receive little academic credit, that is, not be an author on resulting publications. Some remarkable new therapies emerged in the decade I directed our center. These did not just treat the symptoms of CF, but actually changed the abnormal protein from this genetic disease, and these medications are truly life-changing. So in summary, looking for a needle in a haystack and finding the farmer's daughter. I found her in pediatric pulmonology during its infancy and maybe toddlerhood, and I witnessed its growth to adolescence, now with apparently unlimited possibilities to enhance and extend the lives of children with respiratory disorders. I was lucky. I've had a wonderful career. I was fortunate to be at the right place at the right time, perhaps most fortunate to have been guided by wise and generous mentors and to have worked with enthusiastic and talented fellows and students. Thank you very much.
Thank you, Tom, for that account of a very varied and rich in accomplishments career. Now we have time for discussion. I see a number of virtual hands raised. I can't always see these things. They keep on my screen. They keep fading in and out. So if I miss you, and don't call on you, just feel free to.
No, I want to raise my hand.
So there were a bunch of hands. There's Valerie had one up, but it disappeared.
No, that was an accident, sorry.
That was an accident. Okay. Well, it's like being in an auction and scratching your head and people think you've made a bid. So please, anybody with questions, comments?
May I offer a comment?
Yes.
My name is Lawrence Ross. I'm retired from Children's Hospital Los Angeles, Peds ID, and I had the incredible opportunity to work with Dr. Keynes from 1973 on, first as a resident under his tutelage and subsequently as a colleague. And I can tell you that, as you can see from his presentation, his accomplishments are legion, and he's an icon and legend forever. But the thing one has to really know about Tom is that he may be one of the most wonderful mentors, kind individuals, and supporting individuals you can ever meet in an academic environment. And I want to thank him for providing not only outstanding care to patients and teaching, but for being just an outstanding colleague. Period. I want to just say one other thing. Unfortunately, 2 weeks ago, we had a memoriam for one of his other colleagues, Dr. Wilbert Mason, who was one of my mentors as well. And between Drs. Mason and Dr. Keynes, I think they comprise the heart of the history and the greatness that is Children's Hospital Los Angeles. So thank you very much, Tom.
So Larry,
Henry.
I have to
Yeah.
tell a quick story about Dr. Ross.
Okay.
So I was a third-year resident toward the end of our residency. I think it was in the spring. And Larry already was enamored with infectious disease. And he brought me an article that described a technique called percutaneous pneumocentesis. I don't know if you remember this, Larry.
Sure.
And he said, why don't you look into this? So the idea was if somebody had lung consolidation and a pneumonia, you would actually stick a needle through the chest into that lung, put some fluid in, and be able to get the bacteria that were causing the disease. So now I was actually technically working under Dr. Platzker at the time, and I'm not sure I ever told him I was going to do this. But basically, we did find a number of kids with pneumonias and did this technique. We had no complications from it, which was, first of all, amazing. But I'm not sure we ever made a diagnosis with it. To be honest with you, I don't think it really worked out very well. So I did not pursue this in my subsequent pulmonology career.
I'd like to add something. I'm Henry Foreman. Tom and I have a long relationship. He's actually my daughter's godfather. I joined Children's Hospital. I'm a basic scientist, and I joined it in 1986. I then moved down to the health science campus and to the School of Pharmacy, and I was put in charge of the physiology course. And I said, pulmonary, who could I get to teach pulmonary to pharmacy students? And I recruited Tom to do that. He did that. He also ended up teaching pulmonary physiology to the medical students. I don't know if he did that all the way to the end when he retired, but he had a great reputation. The students loved him. He was just a wonderful teacher to medical and pharmacy students. And I think that's, in addition to his wonderful research career, is one of the reasons why he is considered a great contributor to science besides medicine.
So Henry, I'm still teaching the pharmacy students. So look, I spent 20 plus years. So I've done that. You know, this is great. I should do this more often. I've never gotten this many compliments.
Well, I think Lawrence Ross has a hand up.
I've already spoken, but I can speak another half hour if you'd like. I have no problem.
Sorry, it's still up. Sorry.
No, I'm sorry. I'll take it down to let other people have an opportunity.
Let's see. Anyone else? Laura? You need to unmute, I
You're
think.
muted.
When was
There you go.
it decided that it was better for babies to sleep on their backs than on their stomachs?
Yeah, that's an excellent question. It turns out around the world, most babies do sleep on their backs. And probably the more relevant question is, why did Western countries decide to have babies sleep on their stomachs? And this probably was Dr. Spock, not the Star Wars Star Trek Spock, but Benjamin Spock, who wrote a series of popular books on baby care. And he reasoned that if babies slept on their stomach, if they spit up, it would roll out their mouth. Starting really in the 1980s, primarily in Australia, England, New Zealand, and the Netherlands, some people started to note that SIDS victims, babies who died from SIDS, were more likely to have slept on their stomachs than on their back. And so that was really kind of the start of it. And then some careful epidemiologic studies were done which confirmed that. But interestingly, if you think about the anatomy, and I guess Dr. Spock didn't do this. If you think about the anatomy, if a baby is sleeping on their stomach, the esophagus or the food tube is above the trachea. So if a baby spits up, this is going to go right down into the trachea and cause aspiration. If the baby is the other way around, sleeping on the back, the esophagus is below the trachea. So if a baby spits up, that material would have to defy gravity to get up and go down to the trachea. So just from anatomy alone, it didn't make much sense to have babies sleep on their stomachs. But really, in the United States, the American Academy of Pediatrics formally recommended babies not sleep on their stomachs in 1992. And the huge Back to Sleep campaign started in 1994, which was a collaboration of a number of things. So it's been, what, 30 years that now that this has been recommended.
Dr. Spock was our Bible.
Yeah, well, you got one of them wrong.
Others
Yeah.
have questions.
I have a
Yes.
question. Okay, my question from the professor is that the baby that was sent home on the ventilator was sent home with a tracheostomy or a regular ventilator?
Yes,
Via the trach.
sorry. Yes, he had a tracheostomy in place. At that time, BiPAP, which is like CPAP that some of you may be familiar with, really wasn't around. And so we were nervous enough about sending this kid home, even with a trach and a ventilator. And I have to tell you, this, nowadays, this doesn't seem so, kind of fantastic or difficult. But at that time, this really was not being done. And the pediatricians in the audience will notice that when I first recommended this or did this, CCS, which funds, provides extra healthcare funding for children who have chronic diseases, certain chronic diseases, they were willing to give us anything we wanted. This was so novel as far as they were concerned that they thought this is really great. Interestingly, many of these kids now go home with home nursing to help. This family said, no, he's our child, he's our responsibility, we don't want home nursing. We could have gotten it for him, but they didn't do it. So yes, this child had a tracheostomy, which is how we hooked up the ventilator. Non-invasive ventilation came probably 20 years later.
Thank you.
Others? Anyone
Arnold,
else?
when you first came to Children's, I got a call from Charlie Bryan, and he said, Tom's should do very well, but don't let him get into everything. You've got to tell him, no, can't do this, can't do that. I failed. You did everything you wanted and succeeded. Congratulations.
With your help, Arnold.
I didn't stand in your way.
You definitely did not.
Oh, that's great. Jerry.
Well, we coped with a first baby with what they used to call hyaline membrane disease, immature lungs, staggered breathing, stuck in intensive care for
6.5 weeks.
6.5 weeks. How have they modified the in-hospital clinical treatment of children with immature lungs now, given your research on staggered breathing and arousal mechanisms?
Yeah, no, that's an excellent question. I'll lean on Arnold to help me answer this. But when I was an intern, when I started at Children's Hospital as an intern in 1972, basically the cutoff of viability was a kilogram or 28 weeks gestation out of 40. We wouldn't even go out and get a baby who weighed less than a kilogram at that time because their chance of survival was nil. Nowadays, we're treating micropreemies who are 500 grams, 600 grams, and they have a reasonable survival. Obviously, that's the cutting edge, and so a number of those babies die. But a number of things have happened. We can administer surfactant to these babies now, which has made a difference, which may not have been true when your baby was born. I think there are different modalities of ventilation. There's an awareness that with the ventilator we can cause damage, and so we can modify things a little bit to improve that. It is still true, however, that babies who are born prematurely do have abnormal lung function compared to babies who are born at term. Now, in many cases, these babies can be virtually asymptomatic, but they probably are a bit more prone to an asthma-like condition and perhaps some trouble with exercise. But their survival, I think, is the main thing, has improved dramatically, and intact survival. I mean, doing well neurologically, et cetera. So, yeah, things have changed quite a bit.
Thank you.
Others? I actually have a question too, which is a little bit to the side of your main subject, but I was very interested to see that you had gone to St. John's. And I've always thought that was such an interesting idea educationally. And you mentioned your freshman year there, but I'm wondering, more generally, has that played any role in your own approach to your career, professional development, however indirect? And would you recommend something like that now to a student who is thinking of a career in medicine?
So I loved St. John's. I absolutely loved it. I got into it in high school. I was sure that I was going to be a theoretical astrophysicist, which obviously I did not ultimately end up doing. And I realized that, you're going to have to go to graduate school and get a PhD if you're going to do that. So I basically decided for college that I wanted to take, and I really thought of it as taking 4 years off to kind of broaden myself and get an education that I might not otherwise get. Now, the other thing about St. John's was it forced you to do that. There are no majors. There's only one curriculum. And I knew that if I went someplace else, I would be tempted to veer over to be a physics major or astronomy major or something like that. I couldn't do that at St. John's. So I had to go through the whole course and learn philosophy, literature, the whole bit. I loved it. I just thought it was wonderful. For me, it was great. It's not for everybody, but I did love it. Now, Getting into medical school, St. John's is not exactly the most popular pre-medical curriculum. And that was another one that many of the medical schools I applied to just rejected me outright. Just said, forget it, you must be joking. But a couple, actually one was USC and the other was UCSD, did take a chance on me, if you will, and admit me. So I think if somebody knows they want to do medicine, I think, there are a number of great things about it. I think one is that you really learn not just science, but you learn the philosophy of science. And I think that has been very helpful. The curriculum is based on reading the great books. And I think, to some extent, reading the great books, trying to figure out what's going on, diving into them is kind of like patient care. You're confronted with a patient, you have to kind of dive in and do that. And also kind of like a research project. So I think it was good training really in critical thinking for how to do that. So I can't say enough about it. I realize it's not for everybody, but I'm glad I did it. It was great.
Jerry.
Would you be kind enough to reflect on your 25 years with the Human Subject Research Committee? I saw the start of it on the University Park campus. I'm wondering how it may have evolved at Children's.
Well, probably similarly. Yeah, that was another thing that things happen you don't plan on. What can I say? So I was a young faculty member, and a good friend of mine that we were actually contemplating doing some research together was on the IRB and left for another institution, regrettably for us. And it was Bernd Sinkson, Arnold. And he recommended me to replace him. Now, at the time, I was one of those that thought the IRB was an obstacle to research. So I said, yeah, get me on this committee. I'll turn them around. But I did learn, and it was a formative time for human ethics research. So the common rule, for example, which is the major legislation. So I started on the IRB in 1979. The IRB, or the common rule, wasn't published till 1980. So I started when we didn't even have official guidance, if you will. And then it took a while for the committee and others to really understand what was in those regulations. Eventually, Primer, Public Responsibility in Medicine and Research, and ARENA, the Association of Research Ethics, National Association, started, and they started holding conferences. And so I started going there and hearing really from some of the icons of ethics and research ethics. So I think we became much more sophisticated. I think in the beginning we were, okay, this sounds okay, but we didn't really have a lot of formal guidance. And I think this became better as time went on. The NIH mandated education for investigators. I'm trying to remember when that was, probably around late 1990s, I guess. And I developed the education curriculum that we used at Children's for a while, and I think that greatly improved things. We had the Office for Prevention from Research Risks, OPRR, which subsequently became the Office for Human Subject Protection. I had a interesting experience. If OPRR went to visit your institution, it meant you were in trouble. And it meant you were in trouble because you were not, in their view, adequately protecting the rights and welfare of human research subjects. So I got called by OPRR, which first of all was nerve-wracking because I didn't think we'd done anything wrong. But they said, we have to go investigate this major university. And we would like an IRB chair to join us, actually 2 IRB chairs to join us, to give us credibility. So I went on that visit, and man, that was an eye-opener. I came back to our IRB and said, all right, these are all the policies we have to change, because I wasn't sure we were doing everything as well as we had to do it. But I think it's important. I think it can be done in a way that is not an obstacle to research. And I hope, at least during my career, that I, in fact, modeled that.
Any other questions or comments? Well, if not, we'll let you off the hook, Tom. But thank you very much for this. It was a great way